Welcome, everyone. I think we'll give it one more minute before we get started. And we are recording this so that people who can't attend are able to see us later. But I'm going to stop the transcription because that shows up in the chat. All right, Kristen, do you want to get us started, or would you like me to get us started?
Either way is fine.
Okay, I'll let you go ahead.
Okay.
I only have a couple slides.
Welcome, everybody. We're so happy that you're here today. This is our first of two identical trainings to introduce you to the Minnesota Department of Health Mental and Behavioral Health Data Collection Protocol that we will be using. Today, you're going to be hearing from three of us. So Alicia Simon is going to be introducing the purpose of this study. And she is coming to us from the Minnesota Department of Health. And then I'm Kristen Dillon, and my colleague Mia Mua Vang. We're both from Wilder Research. Oh, looks like I got muted. So we'll be using the process. We'll be sharing the process we'll be using for data collection, including a live walkthrough of what the data collection protocol looks like. So again, here's our agenda, and we're hoping to be able to have time to answer questions throughout today. So Alicia, I'm going to turn it over to you to talk about an overview of the study.
Great, thank you. So just as a quick study overview, this study is being led by the Minnesota Department of Health, and it is being conducted by Wilder Research. We're basing it on similar studies that were done in Minnesota in 2016 and 2019. And the purpose of the study is really to measure the volume and reasons for behavioral health discharge delays for both inpatient units and for emergency departments. We really want to focus on quantifying the service needs outside of hospitals and in surrounding communities to support behavioral health patients. And it will also help us inform policy and practice within the mental health infrastructure in Minnesota. And the way we created the tool that Kristen and Mia Mu are going to share with you today is we started with a previously used tool that was created by Wilder Research and the Minnesota Hospital Association. We revised it as a team, and then we gathered input from staff and leaders from several hospitals, as well as some community behavioral health providers who had responded to a previous request for information. I'm going to pass it back to Kristen.
Great, thank you, Alicia. And so Mia is going to walk us through the data collection process.
Fine, thanks, Kristen. So while the research will be available to provide technical assistance throughout the study, any questions about data collection, including questions about definitions or how to use the form, submitting data should be directed to me, Mia Vang. I'm typically available between 8 a.m. and 4:30 p.m. Central Time, Monday through Friday. Okay, next, please. So to go over eligibility criteria, this tool should be used to track all behavioral health patients in inpatient care and emergency departments during your hospital's chosen 2-week period for data collection between September 5th, 2023 and October 20th, 2023. So even if they were admitted prior to September 5th, who are eligible to be discharged to a different care setting, but continue to stay in your facility. So hospitals with inpatient psychiatry units should track patients admitted to inpatient psychiatry, excluding partial hospitalization patients. Hospitals that do not have inpatient psychiatry units should track all behavioral health patients admitted to inpatient units. Some hospitals may choose to track patients both in inpatient psychiatry units and behavioral health patients in medical units. And for emergency departments, the data collection tool should be tracking all behavioral health patients that come into the emergency department during the study time period who are eligible to be discharged to a different care setting, but they continue to stay in the emergency department. And for this study, a delay starts if a behavioral health patient is still in the emergency department 4 hours after a disposition decision has been made. And it is up to each hospital to determine when a patient would be eligible for discharge. And to go over what the form is tracking, this form gathers the reasons preventing a patient from moving from a different care setting for the behavioral health issues. So for some of the admission characteristics to be gathered are where they're admitted from or how the patient arrived in the ED, admission dates to inpatient care, and the nature of admission, whether it's involuntary or voluntary to inpatient care. It'll also be asking for patient characteristics. So that includes state or county of residence, the age range, gender identity, race and ethnicity, and insurance coverage. For ED admissions only, they'll be asking for date and time disposition decisions. So as I noted before, the clock for the delay starts about 4 hours after decision for this particular study. It will also collect reasoning for potentially avoidable days, and this includes categories in internal staff delays, core service agency delays, space in safe setting not available, or patient or family delays. It'll also be asking to track patient characteristics that contribute to the delay. So identifying any patient characteristics that are associated with the delay. And if the patient character is not a direct related to the delay, do not mark it even if patient has the characteristics. So just to make a note of that. And lastly, but not least, as it'll be collecting the discharge information of where and when and where the patient is discharging to. We'll be going over when to complete the form. So you'll be completing the form when a new patient is admitted to who meets the eligibility criteria, and then also when the reason changes. So the primary data gathered by this form relates to the reasons preventing a patient from moving to a different care setting for behavioral health issues. It is important that you only endorse one primary reason per entry. If a patient moves from one reason to another, please complete a new form and designate the start and end dates to that pertains to that new reason. So an example of this, a patient is like ready to be discharged on September 3rd, and he remains to be in your care until September 5th because he's like waiting for a core service agency social worker in this county to find him a state psychiatric hospital bed. So you'll be filling out a form and indicate the option that states waiting for a CSA inside county of responsibility to identify and make referral as the primary reason for the delay starting from September 3rd to September 5th. If on September 5th, the social worker finds a bed and there is like a waiting list at the facility until September 16th, you have completed a new entry for that patient using the same ID number and indicate the option lack of bed space in preferred setting as the primary reason for the delay from September 5th through the 16th. And so you'll also be completing the form when a patient is discharged. So you also submit a new form when the patient is discharged from the behavioral health care at your hospital. Even if the patient is transferred into a medical bed at your hospital, we want to track that they're no longer in inpatient care for their behavioral health needs. And indicating that a patient is discharged will close out the case for the purpose of this study. So I'll be providing a preview of the online tool. If Kristen, do you want me to take lead or do you want to run through?
You can go ahead and take the lead. And I just wanted to pause for a moment and say that in addition to this training, we will also be providing written protocols that have the written instructions that we're going over today. So you'll have that you can reference as you're going through the process of implementing this study.
Thanks, Kristen. All right. Does everybody see my screen?
We see the slides.
You see the slides. Okay, let me go ahead and try it one more time. Okay, how about now? Do you see my screen?
Yes.
Awesome. All right. So when you enter the tool, you hit this landing page titled the Discharge Delay Patient Tool, and it'll ask, sorry about that. It'll ask you to select one of the two options below, asking you to start a form for a new patient or accessing a patient that have already been started. So for the purposes of this study, we'll go ahead and start a form for a new patient. So I'll go ahead and click continue. Oh, actually, let's redo. I've had this form up for one moment, please. All right, let's try that again. All right, so once I go from there, it'll pop up this page and assigning a random number patient ID for this patient. So please make a note of this randomized ID number for this patient, and please track it and put it into a safe place, and we'll continue from here. Okay, go ahead and continue. All right, and then from there, we'll go on to a main menu page, and there will be 5 separate options that we can choose from. This first section is asking to enter information about the patient, so that includes admission characteristics as well as patient characteristics. This second option is asking to enter updating reasons for patient's delayed discharge or transfer. Next section is for discharge information, and then 2 other options to close the session or move on to enter in new information for a different patient. We'll go ahead and look into the first option, which is entering information about the patient, and go ahead and press continue. And every time you press continue, it does save your answer. So please notify that. And from here, we'll go ahead and choose the name of the hospital. So please choose the hospital. Please choose your hospital. Right now, we'll just use the example of Adventist Healthcare. Continue. The next page will ask about about their residency, asking if they're a resident as well as their zip code. So let's say they're a resident, and then this is a random zip code. Okay, and just wanted to also make a note that some of these questions will be required. So for instance, if I don't click on any of these and decide to try to click continue, it does pop up a red note asking us to answer the question. Okay, so the next questions will ask how did the patient arrive to the ED? And the options are the family or self, first responder, ambulance, law enforcement, transformer ED, or crisis team or other. And right now we'll just go ahead and choose first responder ambulance as an example. Next question is asking for the insurance coverage at admission. It does allow us to check all that applies, either Medicare, private insurance, Medicaid, Minnesota Care, or they're uninsured. For this example, we'll just choose uninsured. All right, now moving on to patient characteristics, asking for age and gender identity. And let's say they are 30-year-old, and for now. We'll go on to ask more information, race and ethnicity, and then if the next question asks if they require an interpreter at any point during the visit. So if they do require an interpreter and it was requested, but unfortunately it was unavailable, please still note that they did require an interpreter at the time. So let's say no for this patient and continue. The next page will ask for when the patient arrived to the ED, asking you to select a date and time. So if you click on this little mark right here, it'll pop up this handy dandy tool asking for a date and time. So we'll go ahead and choose a random date of the 20th at about noon for arrival. And the next question does ask when the ED decision was made for the patient's disposition that was determined. So please make a note that this study, a delay is defined as 34 hours after disposition was determined. So let's say they came in at noon and a disposition was made about an hour after they were admitted at about 1 o'clock. So if it was made then, so then from here, a delay would technically be starting about 4 hours, could start about 4 hours from here, so about 5 o'clock. Just making note of that. We continue, and from there we're done entering the majority of the information for the patient. We can move on into once they do experience a delayed discharge or transfer. We can move on into that section and press continue. And then when you're entering reasons for a discharge delay, when you're filling this section out for multiple delays, all the data will remain on the screen for your review or for you to be able to update. So being able, if you scroll up and down, it will show you the different entries. So right now we only have one entry available for us to put in. So it asks for a start and date time for this reason. As I mentioned before, they were admitted at 12 p.m. on the 20th. The disposition started at 1 p.m. or a decision was made at 1 p.m. A discharge delay can start about 5 p.m. that day. We'll go ahead and just use that as an example. That day, go ahead and start. And then from here, these are asking you to select a reason for the avoidable hours. So again, please only endorse one single reason from the list below for this particular entry. And if there are multiple reasons, we'll assign each unique reasons for each unique date. So for the purposes of this demonstration, we'll just say there's a delay in creating or implementing care plan execution MD discharge disorders. But there is a list of this. And as Kristen mentioned, we are creating that protocol that will have the definitions stated in there. And then we'll also be providing technical assistance if you have any questions regarding these reasons. If we move down, and from there, it'll ask if there's any of the patient characteristics that contributed to this delay. And as I mentioned, if the patient has this characteristic, but it didn't contribute to the delay, please don't indicate it on here. But let's just say that they experienced a traumatic brain injury that did contribute to this delay. We'll go ahead and check that and move on. So the last thing on this page is asking for like the end date for this read. We'll go ahead and indicate that. As you can tell, nothing is in here right now, and we're getting this red message asking us to enter in that information either now or later on. It's just a warning note. So let's say that there is an end date for this reason, and let's say it's yesterday, the 20th at about 9:20, and we'll set that here. Okay, and then it's moving on to asking if the patient is being discharged at this time. So for this, let's say they're not ready to be discharged yet. We're going to go ahead and continue. It'll be sending us to a comment section and then just returning to the main menu. And I'll show you how to get back to this page. But this comment section is asking for any additional context that you think might be relevant to know about the discharge delay in this patient's experience. Continue. So right back to the main menu. If the patient again experienced another discharge delay, you'll go ahead and go back and go back into their patient file. Make sure that you make a note of the ID and go back to this updating the reason. Go ahead, press continue. And as I mentioned before, the discharge delay reason 1 is still up here for you to review. But once you scroll down, you'll see that there's another opening up for you to be able to input that discharge delay reasoning number 2. If you ever did this and you decide that, oh, maybe they don't have one or they didn't have one, you just go ahead and click the back button and it takes you back to the main menu and you don't have to input that delayed discharge. So let's go ahead and enter the discharge information. So let's say that they were discharged or transferred today at about 11. And then it'll ask where this patient was transferred or discharged to, and this is the list of the options that we have available. And for this demonstration, I'll just put the inpatient psychiatric unit at this hospital. And then we'll continue. And then we'll go into that comment box, just asking for any additional context. If you think it's helpful to add it in, go ahead and continue. And then lastly, but not least, I'll ask you to confirm if this case is being officially discharged. But if you do choose to discharge this patient, you will no longer have access to this case for any updates. So this is kind of the last chance to be able to go back and make any further updates if you need to. Otherwise, we can fully discharge this patient and close out their case. Kristen, do you have anything that I missed for this demonstration?
I just added a note in the chat that I wanted to emphasize that this training today is covering both the ED and inpatient portions of the study. We acknowledge that not all hospitals are participating in both, and we know that different staff are participating in different portions. So the example that Mia showed you here is for the ED study, but the flow is the same between the inpatient and ED studies. It's just a couple of the questions vary slightly based on which portion of the study you're focused on.
Right, it's been spinning. All right, sounds good. I can go ahead and stop sharing. And Kristen, if you want to pull back the PowerPoint for me.
Sure. I think, Nate, you had previously shared. Thank you.
All right, thank you, Nate. All right, so as I mentioned, be sure to document the ID somewhere safe. The purpose of the identifier is to link multiple entries for the same patient and to reduce the risk of duplication across the forms. So to document this ID somewhere safe so you can access it later to update entries for this patient, but others not involved in the study cannot access it. So if you are updating information about a patient already entered into the system, you'll make sure to type in the ID number randomly assigned to the patient when you created the original record for that patient. As you have seen, just what I just showed, it was a red number that popped up the second page. It is important that you keep track of this patient ID number as well. The research has no way to identify who the number belongs to. So another tip is to find ways to identify ways to work this data into your daily workflow. This could include designating one person responsible for reviewing all the patient cases at the end of the shift to see if there are updates needed. It could include logging into each patient's record daily to see if there are updates needed or enter new cases. It could include posting a reminder on paper or electronically on the devices used for updating the electronic health records. In Minnesota, in our previous studies, a lot of hospitals chose to discuss this during your group case planning or supervision meetings, or identify any other specific triggers in your work for updating forms, such as when making a call for a referral or sending in a new authorization request. Another tip is that if you need to leave the tool for any reason, clicking that continue button will automatically save everything that you've already entered. When you do re-enter the system with the patient's ID number, choose the section of the tool in which you left off of in order to complete your entry. So for instance, if you had left off at question 6, asking about the patient's residence, you go ahead and click on the entering data for a new patient button, and then on the landing page, and then you can go in and finish updating the information about that patient. And in regards to the privacy and confidentiality of the tool, names and any other identifying information are not to be included on the form. And then the identification numbers that are randomly assigned to them will be used only for tracking forms within the study. So we do ask to store those ID numbers separately from other patient information, only for your team to know. That was the gist of the data collection process. If you guys have any questions for us, we are also providing protocol for this study. So.
And before we dive into the data collection definitions or the definitions for those reasons for a delay, we just wanted to pause for a moment and make sure that we answered any questions about the process.
Feel free to raise your hand, or if you want to put something in the chat, we're happy to read it. One question I wanted to ask is, do you have suggestions, or in the past, where people have stored the ID number? Just wondering if that could be helpful. And then we do have a question about if you can clarify from the ED perspective, if we recommend discharge and there's no place to discharge to, we start this. However, if they're recommended to go to inpatient mental health and there is a wait longer than 4 hours, are those also documented? And I think the confusion is, when would you select admit to inpatient psych if you're recommending discharge? This is related to the ED.
Yeah, this is such a great question. And so I think one clarification, in order to simplify the language, we are referring to these as discharge delays, but they are also transfer delays. And so we do acknowledge that not all patients are discharged, some are transferred. But yes, so to answer your specific question, if the wait is longer than 4 hours from when you've made the decision that somebody is supposed to go into inpatient care, then we would start tracking that as a delay using these forms. And then Alicia,
Thank
I'm
you.
sorry.
I was
I
just going
missed
to
your-
clarify too, then, does that mean like if they're at a site where there is a unit, that doesn't mean they always go to that unit? And so it doesn't matter if they're at a site where there's a unit attached, it's any site.
Exactly. Yep. So
Okay.
whether they're transferred to an inpatient unit within your same hospital or an inpatient unit at a different hospital or different facility, we would still track it. Yes.
Thank you.
Oh, and then Alicia, your question was about places that people have stored the IDs in the past. Yes.
Yeah.
So we have gotten feedback that there are a number of different ways people have chosen to do this. So one way has been like a document on a shared computer or within your shared drive that has a list of the patient ID numbers from this study and their initials or some other form of ID that the hospital staff would be able to recognize, and that's stored separate from any other patient files. Another way that we have seen this happen is if your EHR system does have the opportunity to have like an open text box or a comment field, we have seen people put the patient ID number for this study into that field. Again, the assumption is that only the people that need access to the EHR system for that patient would have access to it, and nobody else would be able to link the study ID number to that patient, other patient identifiers. We have had some old school systems where people have a written list that's stored in like a file cabinet in a shared space. So I think the key is that we really, really want this to be part of a workflow that makes sense for your hospital. So in some cases, there's one person that's tasked with doing this data entry on behalf of all of the staff at a specific facility. And so in that case, that person may identify their own system for tracking the ID numbers that doesn't need to be shared across other staff. However, in a lot of cases, there are multiple staff who are accessing the system. And so needing to have an arrangement that allows everybody to have access to what they need is important. And in those cases, we want to balance privacy and protecting patient confidentiality, which I know you always are thinking about, and having access to those ID numbers. And if you have ideas of how you think you might do this or how you've done it in the past studies, if you have participated in the past, we welcome you to enter those into the chat to brainstorm with each other too. Well, if you do continue to have questions as we go, please don't hesitate to raise your hand or stick it in the chat. We will also have a pause for questions after this next section. So I'm going to spend a little bit of time today covering the data collection definition, so really digging into those reasons for discharge or transfer delay. One thing that I want to note as I go through these is that you're going to see a little I or E after each reason. Those identify whether this is a reason for the inpatient portion of the study. Those are the I's, or the ED portion of the study. Those are the E's. If you see both letters, it means that these reasons pertain to both portions of the study. So this is one of those ways that the two forms look a little bit different, even though the process is the same. So the first set of reasons is internal staff delays. And these are when a patient may meet the criteria for being discharged, but there are just paperwork or process delays within the hospital that are slowing things down. So these could be things like delays in ordering necessary meds, labs, consults. These could be delays in missing documentation or needing signatures. These could be delayed follow through with written physician orders due to staff, due to equipment. These could be waiting for testing or lab results. These could also be delays in the social work department. Often when we see these types of delays, they're happening during non-business hours. And so not all hospitals have staffing at all times that can implement each of the steps that are necessary for discharge. So we often see these reasons on weekends or late at night. And so we know that some of these reasons are not necessarily preventable, given staff workloads and internal infrastructure and all of the different steps that are necessary. And these reasons are not going to be used in any way to penalize a hospital system. We just want to track this information to better understand how these factors flow into some of the other reasons that we have listed that I'll be covering momentarily. So the next set of reasons are really focused on external social service or government delays. And so this is when you have identified a type of placement, but you are waiting for specific authorization or assistance with a referral from a social service agency or government agency. So this can include waiting to identify a facility for a referral. This can include making referrals for placement following discharge, requesting financial records for a referral. These are the things that you're needing somebody else within a social service agency or government agency to do in order to move the referral forward. These are not associated with a lack of bed space in these referral settings. Those are a different subset of reasons. In addition, under the same umbrella of external social service or government agency delays, this is also where you're going to find delays associated with things like MnChoices or CADI approval. So when somebody is waiting for approval or rate negotiation for a service, that would fall under here. If they're waiting for their MnChoices assessment in order to be eligible for a service, that would fall here. Also awaiting MA benefit activation. So this could include somebody who is trying to get on MA or somebody who's trying to restore MA after a lapse in coverage. This also can include waiting for a health plan, whether that's a private or public health plan, to authorize the next level of care, such as residential CD treatment or a state hospital or a home-based service. That could all fall under this category. And then finally, awaiting a county appointment of or decisions around legal guardianship. So if you need a legal guardian appointed in order to help make a healthcare decision, that would fall under this category as well. This category also includes delays due to patient civil commitment. And so this would be, for instance, if a patient is admitted and is in the commitment process, even if they're stabilized and your staff feel that they are able to be discharged to a different level of care, but they need to remain in the hospital in order to fulfill their commitment process, that would fall under this category. We also have transportation delays, and I just want to acknowledge that transportation delays can be associated with social service or government agencies, such as waiting for an MA transfer. But it could also be a private transportation delay. And so either type of transportation delay can fall under this category on these forms for the purposes of this study. And then we have this other outside social service or government agency delay. And this is kind of the catch-all for anything else, such as child protection, county committee decisions, things like that. The next big umbrella that we have for the reasons for a discharge or transfer delay includes a lack of space or wait list in a safe setting. And so this is where you're going to see reasons such as that inpatient psychiatric bed not available. And again, that could be an inpatient psychiatric bed within your hospital system or in another hospital or another setting. That can also include specialty inpatient psychiatric beds. So even if you have an inpatient psych unit in your hospital, but it doesn't necessarily specialize in adolescent care, it doesn't necessarily specialize in co-occurring disorders, so you're waiting for a bed in another facility that does have that specialty, that would still fall under this category. We also have the state psychiatric hospital bed unavailable, and that includes AMRTC, the Minnesota Security Hospital, and CBHH. One thing that we want to acknowledge is that we know that often, because of the difficulty in getting into the state psychiatric facilities, those are part of some concurrent planning with other placement settings. And so what we would ask is that you prioritize the type of setting that your staff believe to be most appropriate for the patient. So if you're working on either getting a patient into the Minnesota Security Hospital or an inpatient psych unit, we would want you to identify the facility that is your ideal placement or the placement that you believe is most appropriate for the patient when you're tracking those days. And then we also acknowledge that not all patients go into psych units. So you may be waiting for a hospital bed for a medical need. And so that's another type of reason that you could endorse. We also have, under this larger category, many of the other types of facilities that we often see patients referred to. So if you are waiting for a bed in any of these settings, you would identify that as the reason that your patient is experiencing a discharge or transfer delay. Again, we want you to identify the setting that you believe is the most appropriate for that patient, even if you're doing concurrent discharge planning. Under this larger category, we also have a lack of housing as a potential reason, and that's if the person doesn't have access to safe housing or housing that's conducive to their rehabilitation. And then finally, we have lack of access to outpatient services. So that could be lack of access to follow-up psychiatric services, lack of access to medication or medication monitoring support. It could be lack of access to partial hospitalization, whatever is necessary in order for a patient to be safely discharged, we would include under this category. And then the final overarching category that we have is patient or family delays. And so we've broken this down into patient non-adherence to the plan of care or refusal of placement. And so this is if the patient themselves is not cooperating with necessary paperwork, follow-up, they don't like the referral that was made to a discharge setting. If they're delaying completing paperwork or following orders, or they're not participating in other parts of their care plan, then you would endorse this option. We also have lack of consent or cooperation by a decision maker. So this is if the parent or legal guardian is not cooperating. And so this is if they're not consenting to the discharge planning, if they're not necessarily willing to do the follow-up in order to allow the placement. For instance, they're not willing to work with their insurance to obtain authorization, or they're not willing to transfer a patient themselves. It could also be if the family is not willing to take a patient home, that you might end up endorsing this reason. And then finally, patient criminal legal involvement. So this is different than civil commitment. This is if the patient themselves is involved in the legal system, such as through warrants, pending court proceedings, and or probation, and that is interfering with their discharge placement. So we have just a couple of case studies that we wanted to share with you to serve as some examples of how we would fill out these forms based on real life patient experiences. So these case studies have come over the many years that we've been doing this type of work, and different hospital systems have shared their real stories of real patients, with obviously names and identifiers changed, to serve as a helpful example. So the first example that we're going to share with you is about an emergency department case. And so in this situation, we're talking about Jason, who is a 24-year-old male who was admitted to the emergency department on September 15th at 6 p.m. I'm not going to read all of the details about Jason to you. You can see it on the screen, but there are some important things that I want to highlight. So Jason was admitted at 6 p.m. on the 15th. At 8:30 p.m. on that same day, the ED team determined that he should be admitted to their inpatient psychiatric unit. So that's the time that that disposition decision was made. That means that if we're adding 4 hours to the 8:30 p.m. time, at 12:30 a.m. the following day is when his clock starts for a discharge or transfer delay. So when we see that he's transferred to the inpatient unit the next morning at 8 a.m. So from 12:30 a.m. to 8 a.m., that would be the time that he'd be on a delay. And for that delay, the reason would be that he's waiting for a bed in an inpatient unit. Jason is then discharged to be home with his father. So that closes out that first episode of care for Jason. We would go through the process of entering that discharge information as Mia showed us, and we would close out that case. On October 14th, Jason has an incident at a grocery store and is brought back to our ED. At this point, we start a new case for Jason. He gets a new ID number. Even though it's the same person, we're not tracking people in the study, we're tracking delays. And so this is a new set of delays that Jason is experiencing. This time, he's admitted to the ED at 11 a.m. and at 3:30 p.m., the team determined that he should be referred to a specialized inpatient unit in another hospital, and they make the referral. So given that the disposition decision was decided at 3:30 p.m., the clock for a delay would be starting at 7:30 p.m. if he's not yet transferred to a specialized unit. We can see here that indeed he was not, and so at 4:30 p.m., the specialized unit approves his referral, but they don't have a bed available. And so that means that he's waiting for an inpatient bed at the specialized facility. On the 10th at 3 p.m., they decide that this referral just isn't going to work out for Jason. The time that they would have to wait is far too long. So they change their discharge plan to pursuing a placement home for him. So at this time, the reason would change, even though he's still on the same delay. So we would close out the reason for waiting for an inpatient bed at 3 p.m. on October 15th, and we would start a new reason at that point in time. We can see from the detail here that the new discharge placement that they're pursuing is home with family, but his family is resistant to the plan, and they are not willing to follow through on the medication management that's necessary for him to safely return home. So at this point in time, the reason would change to lack of cooperation of the parent or the guardian. You can see here that there's additional detail about Jason, such as the staff is starting to pursue guardianship. However, that does not affect this specific discharge. And so that's extra information that's important context. And so we would ask that that could potentially be entered into that comment box that Mia showed us, but it doesn't actually create a new reason for his discharge delay because he is still discharged home. And then that would close out this second episode of care. I see that there's a question. So in that first instance, the same case number transfer from the ED. Oh, that's a good question. No, we are treating the ED study and the inpatient study as two separate portions. And so they would not transfer the same ID number over. And we don't necessarily know that a patient who experienced a discharge delay in an ED will go on to experience a discharge delay in an inpatient setting. It could very well be that once they're placed in an inpatient setting, they get the care that they need and they're discharged at the time that they need to be discharged. So it would be a unique case with a unique ID number. That's a great question. I appreciate that. Okay, now we're going to go to an inpatient case study. And so again, there's a lot of background here that I'm not going to read to you, but essentially we're talking about Sarah, who is a 16-year-old who has a history of oppositional defiant disorder and depression and self-harm. Sarah is brought to the emergency room after a suicide attempt, and she's receiving medical care. She is, originally they're pursuing a discharge delay with family. And so you can see that they arranged for her to be discharged on September 21st. So that's when the clock starts for discharge delay for the inpatient setting. But just prior to the discharge, the parent decides that she is not willing to take the daughter home with her. So that particular discharge plan is not going to work in this case. And so the social worker then tried to find another responsible relative to take the child home, but it was not going to work out. So those all fell through too. And so from the point of September 21st until a different plan is identified, the reason for the discharge or transfer delay would be a lack of parent or guardian cooperation. And then on September 28th, staff start pursuing foster care placement for Sarah. And so that would change to a different reason. From September 28th and then until 1 week later, the reason would change to waiting for a foster care placement from a social service or government agency. And then you can see here that the following week, Sarah is placed in a foster home. And so from the point that the placement was identified to when she was actually placed, that would be another week that would be attributed to a foster care bed, waiting for a foster care bed as the reason. So Sarah experienced 3 different reasons for her discharge delay during this period of time. So we just want to pause briefly and see if you have any questions about these discharge delay or discharge or transfer delay reasons.
I have a question. Well, 2 of them, in fact.
Sure.
Well, I work in APS at HCMC, so the psychiatric area. So there are a lot of patients that land in the ED first that might have a psych issue. Or we are full and they're kind of parked there until we can send a provider over there to see them, or we can get them over to our area. So is the ED over there supposed to start that, or do I worry about it when they land here in APS?
That's a really great question. And I think that I can tell you what our ideal scenario is, but I want to emphasize that we really do want each hospital to identify the process that's the most appropriate for their workflow and patient care. And so from our perspective, we would love to gather information from about as many patients who are experiencing a delay as possible. And so regardless of where that delay is starting or where that care is starting, we would love to be able to track that information. With that being said, we do want to reduce barriers, and we want to make sure that the information that's gathered is meaningful. And so I think if it is more feasible for you to put boundaries around which patients are included for your specific hospital, we would certainly honor that. Alicia or Nate, do you have anything to add to that?
I don't, although I'm not sure like I understand it as well as you do, Kristen, but I would say like if the person is in the ED, I would assume the ED would be the people handling it, but it sounds like you send people over. If I'm understanding correctly, you're sending people over to the ED to sort of help out.
Well, we're across the hall from the ED, so we are like the
Okay.
psych ED. Sometimes we're
okay.
full, and so a patient might come to us, police or EMS, and we're full. They will go over there, and they'll either wait for a bed to come back to us, or if we have a provider that is available, can go over there and see them. That might be what will happen.
Okay.
Does that make sense?
Yeah, it makes perfect sense. Yeah, I guess I think Kristen's answer is great. Whatever works best for you. If you can track all patients, whether they come to you or the regular ED because there's not space, that would be great. If you can only track regular ED patients versus psychiatric ED patients because that's what works best for you, or vice versa,
Right.
that would work too. So, I mean, obviously, the more data, the better, because it helps us understand some of the problems. But I know you are in a unique situation. Most hospitals don't have a situation with a separate ED.
Right. My second question is, now, when you were talking about adolescents, obviously we do not have an adolescent inpatient psych unit. So we do get adolescents. They either land in the ED or they come over here. Usually they come over here. And we try to get them, this is an example, like we had somebody over the weekend, could not get her placed anywhere. Every place is denying her. She's too high acuity. So finally, yesterday, we were able to get her up to the medical inpatient peds unit. So really, she's gone from our department. Now she's inpatient peds. And so their social workers are taking over, trying to get her placed somewhere.
Yeah.
So so the care with us over here has ended and she's gone up there. I should not have to worry about her case anymore, correct?
Correct. So I think from our perspective, then she would move over to an inpatient case, and depending on what your hospital decides with regard to whether they're looking at only patients that are in an inpatient psych unit versus patients that have behavioral health needs in a med surg bed, she may or may not end up in the study for the inpatient side.
Got it. Okay.
But yes, you're right. As soon as she's transferred out of your emergency department, you are no longer responsible for tracking her.
Okay. Thank you.
Any other questions? So the last thing we just wanted to cover briefly is our plan for analysis and reporting. And so after you all contribute your valuable time to the study and you share this really important information with us, we will work to analyze the results, to aggregate them across the hospitals, and make sure that we have cleaned up any important information, including the timing and the reasons. And then we will develop an aggregate report, and the Minnesota Department of Health will be the first party to receive this report. And I know that they've expressed commitment to sharing the aggregate information with all of you. In addition, we are able to do hospital-specific data tables. We have done that in the past, if that is of interest for your specific hospital system. Those would only be for the purpose of serving your specific hospital. They wouldn't be shared more broadly unless you chose to do so. So You would need to request those data tables in order for us to do them, but we're happy to do that if you would find this information meaningful. Alicia or Nathan, do you have anything to add about the reporting plan?
It's definitely our intention of releasing at least some information from the aggregate report. I can't say if we'll release like the whole report or just kind of key findings. But as someone who is participating in the study, we want to thank you. And one of the ways we can thank you is to share the report with you. So we will happily do that if you have specific questions after the study. We're happy to answer them as best we can. And we have one more question in the chat. Just for the first few minutes, do we do this on everyone that lands in the ED? I
Sorry.
think that's kind of a no. That's
Yeah.
okay. It's a good question, and
I
it's
was
sort of a
typing
denominator.
I was typing so fast,
denominator
didn't get it right.
Yeah.
But yeah, I missed the first few minutes. So does everybody that lands in my department when I'm doing these days of study, that's in it? Are they all in it?
So for this study, we are only tracking patients who are experiencing a discharge or transfer delay. So on the inpatient side, that's anybody who is ready for discharge or transfer, but is unable to be discharged or transfer for any reason. On the ED side, it's any patient who remains in your ED 4 hours or longer after their disposition decision has been made. So you do not need to track this information for every patient, only those who are experiencing a discharge or transfer delay.
And I would just add the reason for that is because it sounds like we can get sort of that denominator, like how many patients did you see during that 2-week period from like an EHR poll or from hospital data. So we wanted to make it as easy as possible. So only the delayed patients have to have this information. And then we'll just use that to, the denominator will just be everyone.
Well, that's all we have to present today. I just want to reiterate that Mia is going to be available throughout the study period. So if you ever have questions, she can be your first point of contact. I'm also happy to answer questions. And we really want you to feel supported throughout this process. So if there are ways that we can help make this easier for you or help provide clarity, we're always happy to do that.
And I just want to thank all of you again. We have one more in the chat. The time frame for the data collection is 2 weeks. And yes, we'll have like a 45-day study period. You will pick the 2 weeks within that study period that work for your hospital. And that's part of it is we decided to do the 2 weeks instead of 45 days for that reason. And we have a request to reshare Mia's contact info as well, which may be on the last slide.
No, it should be, but
Back. There it is. And we can send it out to everybody who attended as well.
and it
And
will
again,
be in
we
the
are
written
recording.
protocol. Thank you all so much. It was great to see you, and we really appreciate you taking the time to be with us today.
Yes, thank you. Thank you so much.
Thank you.